All right, well, we will begin. My name is Fonda Buckles. I'm one of the managers here with Dr. Cog. I'm the manager of community resources, and I get the privilege of introducing our topic today. So what we're going to talk about today is nutrition. There's a couple areas we want to talk about: access to nutrition in our region. Do we have equitable access? And what are the gaps that we have accessing nutrition? We're going to talk about the impact nutrition has on aging adults. We're also going to talk about some local resources that we can access. And we have a local nonprofit here joining us today. We're going to learn about what they do, some of their innovative practices, and how they are meeting the needs of older adults with more complex needs. And so hopefully after today's webinar, we're also going to talk about, we also want to engage folks to figure out what are some next steps we can do. So hopefully we're going to learn a lot. And we're also, I forgot to add, we're going to have a lot of data. We're going to share a lot of data. But hopefully at the end of the meeting, we're going to inspire folks to figure out what are the gaps we need, and how can we collectively work together to make changes in the future. All right, well, then I'm going to start off by introducing Jayla Sanchez Warren. I think everybody knows Jayla. And then take the floor, Jayla.
Great, thank you. If you don't know me, I'm the director of the Area Agency on Aging. Welcome to this. You may know that this is part of a series of webinars that we've been doing to provide education and information about the growing demographics of older adults. It's the fastest growing segment of our population, and what some of their needs are. It came about as a result of a summit that we had with the county councils on aging and the commissions on aging. We got together and they said, you know, we just need more information to be effective advocates for the people that we serve. So that was our goal. This is the fourth in a series of webinars. The first one was on demographic and the demographic change. The second was on the most recent consumer assessment survey of older adults. We did a big survey of older adults and asked them what they wanted as a part of our 4-year plan. The third one was on the 4-year plan. All of these can be accessed on our website if you're interested. And now we're going to do one on nutrition, a very, very critical need for the aging population. We have Leanna Kaninsky with us. She is the nutritionist at the state and is over all things nutrition when it comes to the Area Agency on Aging. Leanna, welcome so much. Thank you for being here.
Thank you so much, Jayla, for helping me. So I work at the Colorado Department of Human Services, just fill in a little bit, at the State Unit on Aging. And I am a registered dietitian, and I work with the Older Americans Act nutrition programs and a lot of other aging services. But nutrition is something that I've been in the field of for over 2 decades. And my specialty, just like in medicine, you have orthopedic doctors, family doctors, pediatricians. My area of focus in nutrition is older adults. So that's been what I have been doing, and it has been something I've truly enjoyed over the last couple decades. And I've been at the state for almost 2 decades, which is hard to believe. Before I came there, I worked for Volunteers of America. So I was an Older Americans Act service provider in Larimer County and in Dr. Cog for 7 years. So I appreciate the day-to-day delivery of services. I've been there myself and know how important that is. So I'm going to share my screen. I'm going to attempt to share my screen, right? Kelly, I can just hit it and we can go. And I have some slides, and I have like tons of research, but you can stop me at any time because I don't want to drone on. There's a couple of things that I really want us to focus on and talk about, and then we can switch over because you have a lot of great topics. And I saw Nick's on from Project Angel Heart. So Nick, you saw a little bit of this last Thursday, so bear with me because some of it is a repeat. We had a huge nutrition training last week. So I am going to share my screen and we're going to get started. I'm going to turn this into a slideshow. Can you see it and everything looks good?
It looks great.
Yep.
Okay. So I really like this slide because it shows all ages of people. And really, we are kind of grouped, when you look at aging in general, we start aging when we're born. So there's no denying that from the moment of really conception all the way to death, we're aging. And nutrition looks at aging really from different life stages and different perspectives, because it has a different impact on varying life stages. And when you're pregnant and you're through conception, nutrition is vital for the growth and development of the unborn. And then as you're progressing into infant and toddler, we're looking at growth, just huge amounts of growth, and continuing throughout the life stage, we're building strength and we're maintaining health. And then as we progress through the different stages of life, nutrition has a little bit of a different impact. We're looking at quality of life, disease management, but the amount of nutrition that you need and like the nutrients that you need, really, they're the same. You have to have calcium, you have to have vitamin A, you need protein throughout the entire life cycle and our entire through the different life stages as we age. So that's really kind of the same. Now, the amounts of different nutrients that you need for an older adult might be slightly different than somebody who's 15, but you still have the need for those nutrients throughout the life stage. They just have a different role and they have a different impact. And when we look at nutrition as it relates to older adults, we really see how it impacts quality of life in a very different and unique way. And this next slide it's old, it's from 2005, but I think it gives a really nice view, a visual of impacts of quality of life on older adults. And so as you look at the circle, the closer you get to the inside, quality of life, that's an individual's quality of life, the more impact there is on quality of life. So you have community on the outside, that has some impact for sure, especially when we talk on my next couple of slides of social determinants of health. Then you have family and caregiver with a little bit more impact than general community. Then you have a person, your own individual impact on quality of life. And these are all the different things that impact older adults' quality of life: disease management, physical activity, living arrangements, physical, mental, emotional functioning, nutrition and well-being. So this inner circle has the most impact on an individual's quality of life. And I want to point out, so nutrition and well-being has its own section, but we all know that it has like this synergistic bouncing, like an atom or a particle when it interacts with itself, with health status, with disease management, with physical, mental, emotional functioning, with physical activity. So nutrition, not just in and of itself impacting quality of life, it impacts all of these other aspects that impact quality of life of older adults. And this was done in 2005. And social determinants of health really was just kind of starting to kind of bubble up. It kind of really, like the very first thing I saw of social determinants of health was from the Robert Woods Johnson Foundation around 2008, 2009. And so this is in some ways a little bit of a precursor to social determinants of health, because when we look at social determinants of health, we know that food and food insecurity is a social determinant of health. So these are the social determinants of health. We've got education, access, and quality, healthcare access and quality, neighborhood and built environment, social and community context, and economic stability. And so if you were thinking about that quality of life slide with the circles that I had before, you can kind of see the impact of quality of life and social determinants of health having some overlapping. And so when we dig a little deeper into the social determinants of health, because food access and food insecurity is a component of the social determinants of health, here we see like an overlay of social determinants of health and then basically risks for malnutrition in older adults. And so it's an overlaying of these two. And you can see how all of these different impacts, when we're looking at social determinants of health, totally impact malnutrition in older adults. We have hunger and food insecurity, because food insecurity in and of itself is actually a risk factor for malnutrition. And then we have, basically health literacy risk factors. If we're providing information to somebody not at appropriate literacy level, and health literacy is a subject unto itself, it makes it nearly impossible, or if you don't even have access to health and information, how that is an impact for malnutrition in older adults. We have a lot of disease-associated risk factors that increase risk for malnutrition. And then we have functional associated risk factors, right? Can we get to the grocery store? Do we have access to the grocery store to get that nutritious food that we need? And then there are social and mental health risk factors for older adults. So this is just kind of an overlaying, and that quality of life slide that I started with a couple back, really, they kind of all blend together. And I like the visual presentation sometimes because it makes the topic a little bit richer when we talk about conversation, and it shows all the different ways everything kind of impacts. But the bottom line is the nutrition has a huge impact on the quality of life of older adults, and it's impacted by social determinants of health. And because food insecurity is an impact or a risk factor for malnutrition, malnutrition is also impacted by social determinants of health. And we're focusing on older adults, but when we talked a little bit about the life stages of nutrition and the impact that has, I just have to call out the social determinants of health is impacting all life stages, and access to food and quality food impacts our entire life stage across our entire country. So we're just talking about older adults here. So I want to talk a little bit about food insecurity, food security, and malnutrition. And I think it's easiest for me, before we talk about the lack, to talk about what it means to have. And so these are definitions. This is what USDA uses. And USDA is really kind of like the driving force of food security and food insecurity programming in the state or in the nation. And it's not the only one. And we're going to talk about the ones that the Older Americans Act programs provide, which many of you are already familiar with, and the huge impact they have on this as well. So food security, and this is really important, right? It means access by all members of a household to enough food for an active, healthy life. So that means it's readily available, it's nutritionally adequate. It doesn't mean that you can just get something to eat, but what you can get to eat is nutritionally adequate. It's nutrient dense. It's not empty calories. It's not junk food, but it's food that we need nutritionally, because remember, we need vitamins, minerals, nutrients throughout our entire lives. And food security means you can get that. It's available, and it's safe food. So our drinking water's safe. It's not contaminated with lead, and we can't go to our own sink and get water, or it's not untested well water that's unsafe. It's safe foods, okay? And we can access it in socially acceptable ways. That's a really big deal, and I think sometimes that's not thought about. And so we're not having or feeling like you have to steal it, that there's other coping strategies where it's like, I'm not going to eat today so my kids can eat, or you know what, if I eat today, that means I can't afford this medicine. No, it's socially acceptable ways, and culture and in being able to access food with the ability that makes the most sense for you culturally is a part of that. So that's food security. So what's food insecurity? Okay, so that means you basically, it's limited or uncertain availability of that nutritionally adequate and safe food that you need. And you're really uncertain, and it's limited as to whether or not you can get it. And can you acquire it in an acceptable way, in a socially acceptable way, in a culturally appropriate way that you feel comfortable in? So that's what food insecurity is. It's basically you can't have, and you don't have access to that with certainty. And it's the exact opposite of food security. That's food insecurity. And then what is malnutrition? That's unbalanced nutrition. that means things are off. You're not getting the nutrients that you need. And there's really two ways that we look at that. Undernutrition, which is you do not have access to proper food, calories, protein. You are undernourished. And that often, where we often see that, are in countries where there is a significant lack of food resource. And then overnutrition can have an unbalanced nutrition aspect to it and be considered malnutrition. And what that is you can get food, but remember when we were talking about food security, it needs to be nutritionally adequate food. Overnutrition can result often when people have access to food, but it's not nutritionally adequate food. And there's something that's called sarcopenic obesity. And what that is an individual is actually obese, overweight, but they're losing massive muscle mass. Sarcopenia is a lack of muscle mass. And it's because they didn't have access to adequately nutritious foods. And so then they end up with this unbalanced nutrition, and it's actually malnutrition. So we're gonna watch this video. And what this is, it's by an organization that's called Defeat Malnutrition, because malnutrition among older adults is a significant health concern. And they have this great video. This organization works to defeat malnutrition among older adults. And it really goes into detail. Instead of me putting like 10 slides, it's a break for you to hear me speak, but it also summarizes the problem of malnutrition among older adults. So we are gonna flip to this, and I'm gonna scroll down here. And let me know if you cannot hear it.
America's hospitals, there is an epidemic. It robs patients.
Can you hear it?
To heal, to endure treatment, even thrive. It hides in plain sight, difficult to detect, and it's difficult to detect by appearance alone. 1 in 3 patients admitted to hospitals today suffers from it, and 60% of those could get worse due to lack of treatment. It causes surgical infections, pressure ulcers, falls, post-operative pneumonia, readmissions, and significant increases in hospital costs. And yet, what if there was an answer to its devastating effects? One that could improve patient outcomes, speed recovery, improve treatment tolerance, even save lives. Such a solution would be hailed as a great advance in patient care. Exactly what hospitals need to combat the malnutrition epidemic plaguing them. The time for what is over. This answer already exists, accessible, affordable, with no harmful side effects. One that's known to improve patient outcomes, reduce length of stay, maintain strength, and speed recovery, all through proper nutrition that assures malnourished patients get the nourishment needed to heal and thrive. Now it's time for leaders to demand the nutrition protocol.
Okay, I'm going to come back to my slides. So that was going through a lot of the impacts and the outcomes of being admitted into a hospital malnourished right from the get-go. The complications that often arise when you are admitted and you're already malnourished are significant. And you heard some of those: increased length of stay, decrease in strength and muscle mass. And it's estimated that 1 out of 2 older adults in community living environments are actually malnourished. And so it's a significant concern for health among older adults. Very significant. It has a huge impact on health outcomes, especially when you are hospitalized. So some of the things that I wanted to talk about was prevalence also of food insecurity. And there's this great study that comes out. It's called The State of Senior Hunger in 2021, with the most recent edition. It was released in April. And it's been done by 2 different universities for well over a decade. And they're looking at what is the rate of food insecurity among older adults. And they're only looking at the rate among older adults. And they take this data from the community survey that happens every December. It's kind of like a touch point. There's a census every 10 years. And then every December, there's a survey that's done to get kind of the touch point of like what's happening across the country. It's across all age groups and all demographics. And they do, as a part of that December survey, the 18-point food insecurity screen, which I'm going to talk a little bit later about. And what that is, it's a validated tool to figure out who is at risk of food insecurity. That's what a screen is. Who's at risk of being food insecure? And in December, they include that food insecurity screen, and it's done all across the country. There's like 45,000 people participate. And older adults are a group of the individuals that are part of that community survey that's done in December. And this group, the State of Senior Hunger, basically, so I'm going to call them. I have all of my resources cited through the PowerPoint, so you can see those. And I think we're going to share slides so that you have access to that. But they comb through all of this data, and they are really looking to see, out of those that are scoring food insecure among older adults, are we seeing certain groups of older adults that are more at risk or that are more impacted by food insecurity? And they find this. And so we know through all of this data and using valid screening tools, when they're combining this data and reporting on it, the communities of color among older adults are at greatest risk for food insecurity, along with low-income older adults, younger older adults, so those 60 to 69, older adults where there is someone present in their household who has a disability, older adults who rent versus those who own their own home, and older adults when there are grandchildren present in the home have greater rates. All of these groups have greater rates of food insecurity. And I'm just going to pull out the communities of color, because Black older adults have a food insecurity rate that is 3 times that of white older adults. That is startling and it's significant. And I like to focus on that because when we look, remember when I told you impact quality of life, and we look at social determinants of health, this right here is an impact of that social determinant of health. And it's significant, 3 times the rate of white older adults. And Hispanic older adults have a food insecurity rate 2 times that of non-Hispanic older adults. These are significant differences. And the social determinants of health have huge impacts into the reason why this is, but you need to know food insecurity doesn't impact all older adults the same way. It doesn't, and you have to apply an EDI lens and a social determinant of health viewpoint when you look at that, and we're combating that. And so I like to point this out because it's significant and it matters. And it matters when we look at policy, and it matters when we look at targeting, and it matters when we look at developing new programs to combat food insecurity. So there are significant health impacts to being food insecure in an older adult. We talked a little bit about those with that synergistic impact when we looked at the quality of life, and when I showed you that overlay of social determinants of health and risk for malnutrition. The one that probably is readily coming to mind is, well, yeah, if you're food insecure and you don't have access, right, reliably to safe, healthy, nutriently adequate foods, you're going to have lower nutrient intakes. And what they found when they looked at that same data, they dug through something called NHANES, which is the National Health and Nutrition Examination Survey. It's a significant survey with self-reported information, claims data, examinations, and it's across all ages across the country. And what they have found when they look through that NHANES data and somebody that's food insecure and an older adult, that food insecurity is actually its own predictor of negative health outcomes and health impacts. And remember when I said, like, life stages, nutrients matter. When you're an older adult, you still need calcium. You still need vitamin D. You still need vitamin A because they all contribute to a healthy lifestyle. So when you have food insecurity and you're an older adult, they found that those that were food insecure had 8 to 24% lower nutrient intakes. That's significant. That's significant for health. And they also had worse health outcomes. And I just pulled out some of these. These are not all of the worst health outcomes, unfortunately. But these are the ones that I thought we could talk a little bit about. So twice as likely to report poor or poor general health, 75 or 74% more likely to have diabetes, which is a significant impact to quality of life. Imagine having diabetes, which is predominantly controlled through diet and food, and you don't have access to safe or nutritionally adequate food. It's significant. 3 times more likely to suffer from depression, 71% more likely to have CHF, is congestive heart failure, which is a very difficult chronic condition to manage. It really causes a lot of fatigue. It can cause lots and lots of fatigue. So those are just some of them. And a couple that I wanted to pull out really have a direct impact to independence. What they found in that study is that if you're food insecure, among the older adults that were, they had a 20% more likelihood of reporting at least one ADL limitation. And we know ADL as activities of daily living. And what that is, can you feed yourself? Can you bathe yourself? Can you get dressed? It's a predictor of your ability to be independent. And this is a quote directly from this particular study, that being food insecure in terms of its association with ADL limitations is roughly equivalent to being over 14 years older than you really are. And I think this is a place that we don't often talk about, but we should spend more time. I want to dig more into this because in the Older Americans Act and in aging services, we consider frail to have 2 ADL impairments. And volume 10 is the rule document that we use for Older Americans Act programs. If you have 2 ADL impairments, you are considered functionally impaired and you're considered frail. Well, look at this, food insecurity, you have a 20% more likelihood to report at least one ADL limitation. So I think food insecurity also has a direct impact to independence and functional impairment. And so when you stop and you think about nutrition and access to nutritional adequate food, it's a huge impact also to your ability to stay at home and remain independent. So this is huge. And I want to spend more time here. And when we start looking at Older Americans Act programs and frailty, food insecurity is not usually one that comes to mind as a separate impact to their ability to remain at home and be independent. But we're seeing data that's saying, I think we need to give that a second look. I think it's not just quality of life, I think it's independence. And so more research, I'm sure, will press into this, but I wanted to make sure that you guys saw that you knew that. So how do we screen for food insecurity? Because it's one thing to say, we have all these problems. What do we do about it? There's nothing worse, in my opinion, to just feel this heaviness of weight of, this is a terrible situation, but what can I do about it? Well, there are different screens that have been developed that are validated, which means they've been studied to show that they can indicate those at risk for being food insecure. That 18-item one, that's the one where all this data is coming from. So it's this robust 18-question food insecurity screen. That's what the USDA uses. And that is what built into all of this research that I was just showing you. There's a 10-item one that also USDA uses. And there's a 6-item short form that can also be used by the USDA. As you can imagine, that's more acceptable than an 18-item or a 10-item question, but it's still 6 items. I have highlighted here a 2-question screening tool that's been validated for the use of children and adults, and it's called the Hunger Vital Sign. And it's more accessible, it's more easily administered, and it still is a valid tool. And I wanted to pull out these 2 screens these 2 questions, because you can add these questions to any of your screens. If you're looking to try to target nutrition services to those that are food insecure, you really need to be adding a validated screening tool to that. Otherwise, you're not really screening for food insecurity. You want to use a validated tool. So these are the food insecurity questions, the 2 questions from the Hunger Vital Sign. and you know somebody's at risk for food insecurity if they answer to either one or both of these, often or sometimes true. Within the past 12 months, you worried that your food would run out before you got more money to buy more. Sometimes or often true is an indicator of food insecurity. Here's the second question. Within the past 12 months, the food you had just didn't last and you didn't have money to get more. Often or sometimes true is an indicator of food insecurity, of being at risk for food insecurity. So those are very simple questions. They're not invasive. They can easily be added to screens. I encourage people to do that. But those are the valid screening tools that exist for food insecurity for adults, because that's important that we use we line the validated tool up with the target group we're trying to reach. And I'm going to pause. Is there any questions so far? And am I doing okay for time, Kelly? Like, do I need to kind of cut? I want to be respectful of that.
Yeah, there are a couple of questions in the chat that I'll share with you, and a max of 5 more minutes, Leanna.
Okay, perfect. Thank you. Do you want to do questions now or do you want to wait?
Well, I'd like to bring out the questions from the chat. So
Perfect.
One question is, how specific is the balance of nutritional content to individuals?
When you say balance, is this person asking about malnutrition when we have an unbalance, or?
I'm going to let Phil, Phil's the asker. Phil?
So part of the question is when you're doing these screens, how to have a broader impact on folks so that we get better information and better help to folks that need it. Most of the screening that I'm aware of happens around hospital stays, and sometimes that's way late in folks' physical process. So the question that I would have is how do we get this out so that we can impact more people in need?
That's a great question, Phil. And these screens can be done at the community level long before they get admitted into a hospital. And it's just a screen. It's not an assessment. And when you're talking about individual approach, individual solution, individual things that you would bring to the table, resources, that would happen after a screen. So these screens, especially this Hunger Vital Sign 2-question screen, can be done anywhere in the community setting. They even use it in healthcare because it's very acceptable for people to complete, but it's only a screen. It's the start entryway. It's not. So you would screen somebody, and if they screen at risk for food insecurity, then you would need to do some additional digging. Tell me what's going on. How are you accessing? Where are you getting? Do you have difficulty accessing? And so then you would do more of an in-depth assessment and resource referral. We're probably not going to have a lot of time, but our congregate and home delivered meal programs and the Older Americans Act actually have research, and they are being recommended as reducing malnutrition from the organization that recommends when we get colon cancer screens, because there's evidence base behind it. From the same organization that talks about when we get mammograms, because there's such great research and evidence behind them as their effectiveness for reducing malnutrition. So that's some of the resources that you can be referring older adults to. But this is just a screen.
Yeah, and Leanna, I understand that it's just a screen, but and I know that you're saying that it can be community based anywhere. But what's that next step? Do we educate folks at churches, at libraries? How do we get to folks in a way that we can because on the other side, isolation is such a big issue for some of these folks. How do we kind of break through that so that we're getting to folks in need? And I'm not necessarily looking for a specific answer right now, but that's the bigger question for me.
And it's a great question. It's a great question.
Leanna, this is Kelly. I think we need to move on to the next presentation. Do you want to make a closing remark?
Sure. I just want to say that nutrition has an impact on quality of life broader than just disease management, also on independence, and that you can do something about it. And we need to target specific groups of older adults with a health equity lens. And if you remember nothing else, that there are specific groups of older adults that are much more at risk for food insecurity. And we need to be looking at targeting services to those groups of older adults. So I'll share my slides, Kelly, but I really appreciate the opportunity to talk. And as always, I'm welcome to any questions further if you would like to talk later. And so thanks for the opportunity.
All right. Leanna, thank you so much. This was great information for sure. All right, so I'm going to introduce our next speaker. Eric Ross is a consultant with 5 Points Geoplanning. Eric is a professional geospatial researcher with a bachelor's in geography focused on urban studies, a minor in criminal justice, and a master's in urban and regional planning, and has a GIS certificate. Since 2007, Eric has worked on projects related to urban studies, environmental science, health and built environment, planning and design, and regional land use economics, providing cartography, data analysis, GIS, geovisualization, instruction, modeling, planning, project management, and research service. Eric also lectured for 7 years at the University of Colorado, Denver, and at Regis University. Eric, we are so glad to have you here. I'm going to turn this on over to you, and thank you.
Fantastic. Thanks for the introduction, and I really appreciate the invite. Just as an aside, I worked at DRCOG for about a year before I started teaching and then did my consulting business. So I feel like I've come full circle, which is really nice. So thanks for having me back. For the last 7 years, have been doing my own consulting work. Before that, even while I was in school, I was a professional researcher, mostly doing GIS work for a variety of studies, whether it was in health and behavioral science or in urban and regional planning or in geography. My work these days is kind of all over the place, but most recently it has been working in food networks and working with organizations like Hunger Free Colorado, the Blueprint to End Hunger in Colorado, Jefferson County Public Health, and other folks. A lot of that came to be during COVID, and it was because some of the work that I was doing prior to COVID ended up being relevant. And in particular, it's what I'm going to share with you today, which is identifying at-risk or high-needs populations and coming up with maybe a different way to look at food deserts, looking at something we might call a food swamp, and then more recently applying those to food networks in some fashion. So that's what I'm going to share with you all. So let me share a screen with you, and I'll try not to be too data wonky. All right. So some of the stuff I want to talk about, I mentioned the high needs populations. I've used this term slightly differently depending on the study I'm doing. The first time I used this work was actually looking at the impacts of the locations of medical marijuana establishments back when medical marijuana became decriminalized in Colorado. And then again, when recreational did. And so the idea was, well, are the regulations that are requiring medical marijuana establishments to locate in certain parts of Denver disproportionately impacting populations that we might call high needs or socioeconomically disadvantaged? I've got a paper on that if you want to read it. The short answer was yes. So that was kind of the first time we did this. And that turned into being able to use the same model for a variety of different things. And so using at-risk or insecure or high needs are sort of interchangeable terms for that. Food deserts is probably something that you're familiar with. The USDA has been defining and mapping food deserts for a long time. They've tweaked it a little bit a couple of times. From my work in Jefferson County and now sort of at the state level, I thought that maybe we should have a different take on that. So I'll share a little bit on the model that we use. We also did a little bit of research on food swamps, and I'll talk about that. And then I want to share some of the Food Network work that we're doing, both at the state level, some work I'm doing in California, and through multi-states throughout the US with an organization called Bondadosa, and then I have a few recommendations for y'all at the end. So not to dive too deep into data modeling, but the model that I'm using for these high needs populations is using American Community Survey data. And the reason we're using that is that it's readily available. Health data is very difficult to get at a geography that gets down to sort of the neighborhood level. So using the American Community Survey data at the block group level, which is sort of small neighborhood geographies, allows us to kind of drill down to where people live, as opposed to looking at something like a county level, which is where you typically find public health data. The indicators that are on here, there are 8 of them, were based from a study that I read from the Harvard Medical School back in the late 2000s. And they had been looking for a way to look at poor health outcomes like cardiovascular disease, diabetes, and obesity. But because that data was difficult to come by and wasn't updated very frequently, they were looking for something like the census or the American Community Survey that they could use as a proxy for those poor health outcomes. So these aren't the exact variables they used, because back in the 2000s, the questions on the census were slightly different. And then the American Community Survey in 2011 started being very consistent. So every year you would get an update. And so that's what we've been using. The reason that we don't just use one variable, something like poverty is pretty straightforward. You can say, hey, there's a percentage of people that are in poverty in this county or in this tract or in this census block group. And that might be an indicator that we have a population that we want to go and offer services to, or ask them what they're missing in their community, things like that. The problem with that is it's one indicator, and you don't get sort of a broad base of like, well, what are all of the contributing factors that might be here? And when we're making an argument to policymakers, what are some of the things that we can bring up that help bolster that argument other than people are in poverty? And so we look at things like income. We do look at poverty. Whether people own their homes, what are the value of those homes relative to the rest of the county they live in, or the neighborhood, or the state? How many people are attaining, educational status? Do they have high school education? Do they have college education, which impacts your ability to get a job? And what kind of jobs do they have? And how many of the people there actually have jobs? So if you could take all of those things and index them, basically giving a rating of 0 to 8, whether these things are present, you can make a pretty good argument that, hey, it's not just one thing that's impacting this community, but it's all of these things. And that also gives you a way to maybe tackle one of those at a time, or a combination of those to sort of make social change in that community. So this is just a snapshot. I'll give you some links to some maps that I'm hosting that have this on here. But this is looking at just Jefferson County. I'm also doing this at the state level for Colorado and California and Texas and a couple of other states, and I'll share that also. But pretty straightforward that it's like, okay, well, if for each of these indicators that we're looking at, this community is below or above average, depending on the indicator, we'll give it a rating, we'll give it a little check mark, a 1, and then we add all those together. And what you end up with is an index ranking of 0 to 8. 0 meaning that none of these things are here. Everything should be fine. That's a community that you would not consider to be high need or at risk or, underprivileged in some way. And the other end of the spectrum is 8, which means that all of those things are present. And hey, maybe we should really be paying attention to that. In the work that we were doing with Jeffco, we sort of decided that anything that had a rank of 5 to 8 was considered a high needs area. And those were places that we were going to focus on. And in particular, at the time, we were looking at food access and maybe what the relationship to whether there were food pantries there, whether those neighborhoods had access to a full service grocery store and things like that. All right. So the next indicator that we look at is food deserts. And food desert kind of typically means that you live someplace where you don't have easy access to a large supermarket or a large grocery store, or what I've termed a full service grocery store. And the USDA has their own definition of that. It's much more detailed than this. I've included a link so if you want to go look at it. And the map on the right is a little bit hard to read, but it's kind of what Jefferson County looks like. And the areas in green are areas that meet the food desert criteria for the USDA. This is back in 2019, so there's a couple of quandaries with the USDA model that I don't like. Number one, it has a minimum population threshold. So if you live someplace where there aren't very many people, and that would be rural areas in Colorado, you may not be counted as having a food desert where you live. That's kind of my number one concern, but also it doesn't get updated very often. And when we talk about accessibility to a grocery store, 1 mile or 10 miles can be very subjective. We went ahead and maintained that 1 mile and 10 mile threshold, whether you're in an urban and a rural area. But we used a slightly different methodology to determine how far away you might be from a store like that. So this is one model. This has been around for a long time. This is an online map you can go look at to, figure out where you might have a, food desert based on the USDA indicators. And they have a couple of different ways of looking at it depending on whether you're in a rural or an urban area. We tweaked that a little bit. And part of the reason we did it is we wanted to normalize our data because we're already using census block groups for our high needs or our at-risk index. So we also wanted to be able to identify block groups that might be a food desert. And so we didn't use population as a threshold. So we just left that out. No minimum population threshold because we wanted to include rural areas that may not have high populations. We used full service grocery stores, which, in the last presentation, there was, some discussion about, what healthy food is. Many years ago, we did a food basket survey. So trying to determine whether, a convenience store or a grocery store or a neighborhood store had all of the healthy food things that you would need: fresh fruit and vegetables, dairy, grains, and protein. And so a full service grocery store for our definition has to provide all of those things. And so that means that, the 7-Eleven on the corner that has a basket of bananas is not a full service grocery store. We're not going to count that. And then we use network analysis. And I won't go into that, but it basically determines how far you have to go on a road to get to a grocery store. And it includes barriers. So, if you don't have a road that goes someplace, or your road has to take a really circuitous route, you may not have easy access to a grocery store because 1 mile and 10 miles along that road network may not be as straightforward as you think, especially when you look at neighborhoods like Elyria, Swansea, or Globeville that get cut off by I-70. Well, you don't have an easy way to get across I-70, so your easy access has been cut off. Same goes for several of the neighborhoods, not just in Metro Denver, but throughout the state. We also looked at small grocery stores that didn't sort of qualify as the full service thing, that may serve as partial access. So, some of our, a carniceria or something like that might provide part of that food basket. And, there are a lot of places where you don't go to a big mega grocery store where everything is, but you might go to several individual stores to purchase your items. So you might go to a farmer's market to get your fruit and your veg. You might go to a carniceria to get your meats. You might get dairy delivered to something like that. So there are other ways to cobble that together, but we're primarily looking at where can you go as a one-stop shop. So as you can see here, this map of where food deserts exist in Jefferson County is a little bit different than the USDA model. To flip this on its head, we also talk about food swamps. And so when we talk about a food desert, we're saying you don't have access to a full service grocery store that has healthy food options. The flip side of that is that, well, you might have disproportionate access to really poor healthy food options. So that might mean you have lots of convenience stores near where you live. You might have lots of fast food or fast casual restaurants. And if you have those and you don't have access to a grocery store, that's a concern. So we looked at the density of these poor food options and coined those as food swamps. So if you were in an area that had a higher than average density of these poor food options, you might live in a food swamp. That's not to say that there might not be a grocery store there, because a lot of times you'll see like a grocery store is an anchor store for a shopping mall. And within that shopping mall, you might have all these other unhealthy food options. So they might balance each other out, but there are places where that is not the case. And so we want to sort of take that into account when we're looking at all of those factors. And so that's what we do. We put them all together. And so we have a high needs index. We've identified the areas that are on that ranking of 5 to 8 that we're calling high risk block groups. We have areas that we've identified as being food deserts because they don't have easy access to a full service grocery store. And we have food swamps where you might have really disproportionate access to a high concentration of poor food options. And when you put all those together, we've got you can see the little red boxes on here. Those are block groups in Jefferson County that we identified as having high risk population, a food desert, and a food swamp. And so that becomes a really good indicator of, hey, let's go work with those folks. Let's see if we can provide some healthy food options. Let's see if we can provide incentives for maybe the convenience stores that is their primary go-to for getting food that's all processed or canned. Maybe we can convince them to get on board with providing some healthy fresh foods. Maybe we can talk to some of the fast food restaurants, fast casuals, and provide some healthier food options for the folks who live there. Maybe we can convince a grocery store to locate in those neighborhoods, or we can tell the folks that live in those neighborhoods that, hey, maybe you didn't know it, but there's actually a couple of food options just down the road here that you may not have been familiar with, to give them some other options. So the way this kind of got operationalized the first time, and this is just sort of going back to the high needs populations, was working with Bondadosa. And they provide food delivery to households with children that don't have access to healthy foods. And this primarily came about because during COVID, students were relying on schools to provide healthy meals, and they weren't going to school, so their healthy meals went out the door. So there were some programs that were, the schools were helping deliver food, or families could go to the school and pick up food. And Bondadosa tried to fill that gap by actually delivering food to homes to mitigate that. And so the little black dots on here are where they do their deliveries. And you can see that, the green to red on here, green means that the high needs are really low, and red means that the high needs are really high. And there's a pretty strong correlation with where they are delivering their food with where we've identified high needs populations. And the model that we're using, that's been verified. We update it every year, and we see the same thing. And we can see a little bit of migration of places that start improving and other places that maybe get a little bit worse. But fairly consistently, there are places that we do actually want to have some sort of community interaction. Working with Bondadosa, we've expanded this project to multiple states. So Colorado's down in the right-hand corner. We started doing this in Texas in the bottom left. Up in the DC, Maryland, Virginia, sort of metroplex out east. We started doing it in California, but that didn't work out. But I'm doing some other work in California where that's being used there. So it's fantastic to see something that we built in Jefferson County that turned into the Denver metro area that became Colorado, and now is being used on a multi-state basis to identify these populations that might need our help. It's a little bit of a switch here. This is I'm going to kind of skip out of Colorado for a second and go to California, but I started working on this project because of work we were doing in Colorado. And the work in Colorado is around food pantries, and there's similar work in every state. And so I got connected with this organization called Fresh Approach in California, and they're managing food pantry grants where they get money and they filter it down to food pantries or farm producers. And that is to increase the networking between those that isn't maybe something as monolithic as the USDA or Food Bank of the Rockies. So I've been doing some network mapping with them, showing where their food hubs are, where the farms that are producing things are, and where their community food distributors are, so we can see what those networks look like. So this is actually some sort of fake data that we played with to build the model to see if it would work. This is some updated data that shows that, hey, this vendor down in Los Angeles, the green lines are to the farms that are sending food to them, and the blue line would be a food bank that food is actually going to. So that would be one example of one network. So we're going to be doing that for all of the food hubs and all of the producers and all of the food banks that they have throughout California. They're ramping up their operations right now, so that'll be really fun to look at. Similarly, we haven't gotten to this point with the work that they're doing, but at some point there's going to be some discussion about whether or not they are serving communities that might be at need, and that's probably going to be more around where the community food distributors or the food banks are. But also maybe some local farming and things like that as well. And we just started doing something similar in Colorado. So here it's a more of sort of just a one-way. We're talking about grantees from the Food Pantry Assistant Grant Program that Colorado Blueprint is running. And the grantees and where they're getting their supplier, where they're getting their supply from. So the map on the left, the little pink dots are the grantees, and the green dots are suppliers that they might be getting stuff from. And on the right-hand side is a map that's just showing one network. I know it's a little bit hard to see because it's at a really big scale. That's just ramping up. We've only done it for 1 quarter. We're going to have updated data at the end of June 30th. And then eventually this is supposed to turn into a database that shows suppliers throughout the state over multi-years so that we have something to work with sustainably. So a couple of recommendations just based on the work that I have been doing. And I know I didn't talk about SNAP and WIC, but one of the things that we've been struggling with sort of all over the state is getting food retailers to accept SNAP and accept WIC. And not only that, including a lot of the cultural food retailers that maybe aren't on board because of the cost or the technology involved. Or their remoteness, because we have communities that are sort of out in rural areas that don't have the same access to that stuff that we do in the metro area. And some of that includes training and technology. So that's something that the Blueprint is addressing. It's something that I think could be augmented in sort of the DRCOG region, because a lot of it is data collection. You know, the USDA does an okay job of tracking who accepts SNAP. And the state does a pretty good job of seeing who accepts WIC, but there's no interaction between those two databases. And there's no sort of regular update. The SNAP update happens every 2 or 3 years, which is really stale. The WIC is a little bit more consistent, but they don't talk to each other. Those databases don't talk to each other. So we've been working on that at the statewide level, but it's a little bit crazy. Connecting local food producers and suppliers, that's become a big thing these days. In particular, sort of during COVID and post-COVID, we sort of saw that our centralized food networks can fail when there's a pandemic. So how can we mitigate that in the future by having more of a local food network? We've seen that be very successful in Europe and other places. Maybe we should think about doing that here. And then something I've been struggling with for a long time is sort of regional pantry cooperation. Food Bank of the Rockies tends to be the big monolithic organization in the room, and all of their tenants fall under USDA and all the requirements that are required. Hunger Free has tried really hard to fit into that, and I think they've got most of their pantries sort of under that umbrella so that they can get food distribution from Food Bank of the Rockies, and now they have regional distribution, which is fantastic. But there are a bunch of other pantries that get left out in the cold because they either are unwilling or unable to meet the requirements that Food Bank of the Rockies and USDA require. And some of that is around refrigeration and how long you keep food on site and what you can accept. So bridging that gap might be something that would be good to do. So I think there might be something in the chat. So from Phil, the commercial food establishments seem to have gravitated to large grocery stores, which are often located not at walkable distances. Do you see a return of neighborhood groceries? Oh, I would really love that. So I think what we run into is economics. And I think it's pretty hard for neighborhood groceries to succeed. An example I can throw out there is in the Five Points neighborhood. There's a location there that's perfect, very, very central, that has tried to be a small neighborhood grocery store like 2 or 3 times. And I just don't think that we have a culture that supports that. Most people are, you know, they're driving somewhere anyway, so they drive to the grocery store either to or from wherever they're going. We also don't have a lot of really walkable neighborhoods. We're still stuck in everybody needs to drive everywhere. We don't have good sidewalks. And as a result, that neighborhood grocery thing doesn't work very well. However, there has been some effort sort of in the new urbanism framework that, you know, neighborhoods are being built around hubs that have a grocery store if they can. So that's been a push for the last 20 years or so. It's worked in a few places, but it's pretty hard to convert neighborhoods. Ironically, like Five Points or Curtis Park that used to have corner stores all over the place, but they're gone now. It's really hard to bring them back. That land has been converted, it's been turned into high dollar real estate. And so if somebody wants to build even a neighborhood grocery store, they have to find a plot of land that is of sufficient size and accessible. So Phil, does that kind of answer your question, or is there more you'd like to chat about? I'll take that.
Hearing-
I was trying to get unmuted there, Eric.
Yeah, go for it.
Thanks for your presentation and your wonderful analysis that's showing many folks don't have access to what would be considered a great range of nutritional options. And the aspect about the neighborhood ones is, what do we have to do to create it? Because I know in working with economic development, grocery stores are looking at basically rooftops or residential units to support their locations. How can, say, even a metro district or a homeowners association or such be in a position, and I'm not looking for an immediate answer, but to be in a position to say, hey, we as a neighborhood want to be in a position to support it. What can we do to be attractive enough to someone? And where are these folks? Lucky's kind of had the smaller grocery store, but they've abandoned Colorado, or it seems so. How do we get the right folks to be in the right place?
Yeah, I feel your pain. I think that there is a constant effort to reuse land. We see, dead zones that used to be strip malls, something that maybe used to be a bank or was a grocery store back in the day in Albertsons, up on North Washington at like 88th, you can see an example of that. And there's been an effort to revitalize that a number of times. I think it really comes down to local purchasing culture, which we don't have. It's pretty hard to convince an individual, a business, or even some conglomerate like Walmart, who's done some neighborhood store work, trying to put in smaller stores in smaller neighborhoods rather than having the super Walmart that you have to drive 20 minutes to. But the economics of it is that you have to prove to those folks that we have the population that will spend the money to support your operations. And they'll do it over a long enough period of time for it to be financially viable for you. With public partnerships, that ends up, on the public side, it ends up being big tax incentives from local metro districts, which I honestly tend to disagree with. I feel like businesses are making hand over fist and they can afford to put into infrastructure for that kind of stuff. But that usually ends up being the trade-off, is that, hey, if you build some of the infrastructure, we'll bring the store, and as long as the economics work out, we can do that. It's not an easy answer. Some of the new urbanist neighborhoods that I mentioned, like, they're built that way. They're built with the intent that there's going to be a community hub at the center of the neighborhood, and that's all baked into the development. But it's really hard to retrofit that in neighborhoods that are already fully built out. Nobody wants to convert that back to, non-residential land, which is much more lucrative.
So
Sorry, I
Eric,
keep babbling on about my planning stuff. Sorry.
that's good. Thank you so much for your presentation. I know there are staff at DRCOG's Regional Planning Division that are very eager to look at your PowerPoint, especially some of those recommendations you had for filling in the data and the mapping that we might be able to do for our region. So thank you. Thank you very much.
You betcha. I will provide a couple links in the chat to this presentation and also to the online map of a version of this that you guys can go play with if you want to.
Thank
I
you.
just want to echo that, Eric. We have limited dollars, and so we got to spend our dollars as smart as we can, and we really need to target those areas where we need it the most.
Yeah.
So we're looking at opening congregate meal sites. We're looking at, expanding home delivered meals. Those kind of maps really help us kind of narrow in on the places that we should be serving. So
Yeah.
thank you.
You betcha.
Okay, well, now I get the pleasure of introducing our next two presenters who are both with Project Angel Heart. Project Angel Heart is one of the programs that DRCOG funds with our older American dollars. And I know every time I hear a presentation about just how much they do for people, it's just amazing. And so I want to introduce Nick Susi. Am I saying your last name right, Nick? So Nick joined Angel Heart in January 2020, and she has moved from the client services department into her current role as government affairs in 2022. So she oversees all the organization's advocacy and policy work, government funding, and research. And then we have Carrie Ann Hunter, who joined Project Angel Heart in February 2021 and works as a client services coordinator, where she connects with and supports their clients and medical referrers. And they both feel pretty darn passionate about the work that they get to do. So thank you both for being here, and take it away.
Great. Thank you so much, Kelly. Thank you all for having us. We're happy to be here, and gosh, have learned so much just by being on this presentation so far. So thank you. I'm going to go ahead and share my screen. So bear with me for one moment. All right. Can everybody see that presentation? Just a quick thumbs up. Awesome. Okay, wonderful. So yes, as Kelly said, Carrie Ann and I are with Project Angel Heart. Project Angel Heart was founded in 1991 in response to the HIV epidemic, but has since grown to serve a wide variety of different diagnoses, including cancer, heart failure, COPD, kidney disease, heart disease, etc. We prepare and deliver medically tailored meals for folks who are living with severe illness. That is our primary qualification. So we work with folks from, as you know, a variety of different backgrounds. We don't have, income, insurance restrictions, etc. To kind of kick things off, I did want to start by just playing a quick video. I will acknowledge this is slightly outdated. We created this during kind of in the height of the COVID pandemic in 2020 for folks who were not able to visit our building in person. So a lot of the numbers, the stats you'll hear are slightly outdated, but I think it gives you a really good sense of kind of who we are and give you a little sneak peek inside of our building. So let me go ahead and do this. So I'm just going to make sure I'm sharing my sound so that everybody can hear it okay.
Hi, I'm Owen Ryan, President and CEO of Project Angel Heart. We're a nonprofit organization based in Colorado that serves medically tailored meals to people living with life-threatening illnesses across our state. Each year, we serve more than 500,000 meals to people who are at home, unable to get the nutrition they need to recover from their illness. Our meals help our clients feel better, experience fewer symptoms, and stay out of the hospital. We're really proud of the work we do, and I could tell you more about it, but why don't you see for yourself? Let's take a quick tour.
For the past 30 years, Project Angel Heart has been making and delivering medically tailored meals free of charge for people diagnosed with serious illnesses like cancer, kidney disease, heart disease, and HIV/AIDS. Our program was born during the height of the AIDS epidemic. What started as a delivery of lasagna to 12 people has grown into an organization committed to improving health and well-being for more than 3,200 Coloradans each year. Our clients come from all walks of life and are living with a variety of life-threatening health conditions. Many are referred by a doctor or social worker, and others find us on their own. We work closely with their healthcare providers to make sure they qualify for our meals and that we understand their nutrition needs. Our kitchen is where the magic happens. Our professional chefs prepare more than 10,000 meals every week. We focus on using high-quality, fresh ingredients while avoiding added preservatives. As a result, our meals are not only nutritious, but also taste amazing. Our registered dietitian and chefs work together to create meals tailored to people's specific needs. We prepare up to 20 different versions of each day's meal to make sure every client's nutritional needs are met.
At Project Angel Heart, we tailor our meals in a wide variety of ways, depending on the conditions and the symptoms or side effects that our clients are living with. For example, someone living with kidney disease needs to limit certain nutrients like potassium and phosphorus, which come from ingredients like tomatoes, beans, and potatoes. So we're able to provide them meals that are limited in those specific nutrients while still providing adequate nutrition to sustain their energy levels and heal their body during treatments like dialysis.
The meals are dished up into microwave and oven-safe containers by staff members and volunteers, and then sealed, labeled, and frozen. Each week, clients receive a bag filled with a variety of frozen meals, fruit, milk, and other food items, packed with love and care, and delivered right to their door. In the Denver metro area and Colorado Springs, volunteers help organize the meal bags into specific delivery routes. Other volunteers pick up those bags and, using their own vehicles, deliver them to clients' homes, in good weather and in snow, ice, and rain too. Our clients know they can count on us. Through partnerships with healthcare providers and payers, we also ship meals to clients who live in other parts of Colorado. None of this would happen without the thousands of volunteers who do everything from working in the kitchen to delivering meals, answering phones, and hand-decorating meal bags. And it wouldn't happen without the donors and partners who fund our work and ensure that our meal deliveries will continue. We couldn't do it without you. So thank you.
Thank you.
Hey, awesome. Thank you all for kind of viewing that. Like I said, I think that just gives a quick overview of really what's going on behind the scenes. You know, you hear home delivered meals, but all of the steps, everything from, you know, getting a client on our service and conducting that intake to finding out, having them talk to our dietitian and figure out exactly the right meal plan for them, and preparing those meals, cooking them, packaging them, delivering them. You can imagine there's quite a bit of logistics involved. So that gives you a bit of a behind the scenes peek at what's really going on. So now I'd like to talk a little bit about what the need in Colorado is. So Leanna actually did a really great job of introducing a lot of these concepts, but we know that there's a really strong correlation between nutrition and chronic disease and chronic illness. And of course, food insecurity as well is tied into that. So we know that 14% of older adults in Colorado are food insecure, and 80% of older adults have at least one chronic illness. More frequently, folks are living with multiple chronic illnesses, which actually make it even more difficult to manage different dietary recommendations. If you have somebody who's living with chronic heart disease, or heart failure, and they're being told that they need to be on like low sodium diet and they need to limit saturated fats. But then you also have somebody who might be living with a cancer diagnosis who's being told that they have to keep their calories up and that they have to be consuming maybe more fats to keep weight. It's difficult to kind of negotiate these different recommendations that folks are receiving from their medical providers. We know that food insecurity, as Leanna covered, increases the prevalence and the severity of chronic disease. And 1 in 3 folks living with a severe illness has to regularly choose between paying for food, medicine, or housing. And we have these statistics from a variety of different sources. Of course, we're using a lot of data collected in the state. And then we also are conducting surveys by sending, we actually send paper surveys to our clients, and Carrie Ann will touch on that a little bit more later. But our clients are regularly informing us that if it weren't for our meals, they would not necessarily be able to afford other basic needs like housing and medication. So we know there's a really great need for food and nutrition, and particularly nutrition that's tailored to folks' medical needs. So that's kind of what sets us apart from other meal delivery programs. We really, the videos shared that we tailor our meals in many different ways. Currently, with every menu item we have, we are tailoring it in approximately 80 different ways each day. And so that's our chefs and our dietitians that are working very closely together to make sure that all of those different modifications are just right for our clients. And all of our meals are comprised of a blend of, healthy, lean proteins, whole grains and carbohydrates like brown rice and quinoa, some healthy fats like an olive oil blend, and then plenty of vegetables. We get vegetables in any way that we can. And our clients are receiving between 7 and 14 meals that are delivered frozen to their door each week. And the reason we freeze our meals is because we think that it gives our clients kind of the flexibility, independence, dignity to choose what they want to eat and when. So instead of saying, here's a plate of spaghetti, it is 12 o'clock, you have 90 minutes to eat this. We allow folks to kind of go into their fridge and say, do I want to eat a chicken meal or do I want to eat a vegetarian meal today? What am I in the mood for? And when they want to eat that. In addition, we also provide nutrition supports. So we have, as I mentioned, registered dietitians on staff, and they are providing nutrition education in the form of flyers into clients' meal bags. They host community conversations virtually, which gives clients the opportunity to connect and not only learn from our dietitians, but also have conversations with each other, have some of that social engagement, and also learn maybe some tips and tricks that work for other folks. We also have individual one-on-one counseling where our dietitians will hop on the phone with our clients and provide medical nutrition therapy and individual counseling sessions as needed. Okay, I'm going to turn it over to Carrie Ann to speak a little bit about our client population.
All right. Thank you so much for having us today. So our clients we serve in 2023 alone, we're going to serve 700,000 meals to over 5,000 clients across the entire state of Colorado. Our clients, 80% are living below the 200% federal poverty limit. 46% have little to no internet access, and about 35% have mental health or cognitive deficit. We've worked really hard to be able to offer the clients access and to really meet them where they are. We've recently updated our breakfast to include more frozen meals, which has been really great and helpful for our clients receiving the breakfast meals. We also try to meet clients that have no internet access. All of our surveys are mailed out, they're paper. And I know other places have a little bit of difficulty with a response rate when you send out paper surveys, but we get over 40% of our surveys back, which is an incredible number. And this helps us determine moving forward what's working for them, what's not working for them. It also allows us to offer them other resources for our clients that are food insecure, such as Hunger Free Colorado, referrals, and different community-based organizations. The top medical diagnoses that we serve are COPD, cancer, heart failure, protein calorie malnutrition, ESRD and chronic kidney disease, as well as dementia. We serve a multitude of other diagnoses, but these are the ones that are definitely the most common among our clients. All right, Nick, if you want to go to the next slide. So this is just a overview of the improvements that our clients year to year. So we send out a 3-month survey once clients have been on our services, and then an annual survey that everyone gets simultaneously. And this is just going to kind of show you how our meals help with different areas of their life, including stress, energy level, allowing them to afford basic needs, their healthy eating habits, and their health regimen. And then below you can read just a couple of client stories. But one thing I want to highlight as far as our clients that isn't really shown here is how much support this also offers to primary caregivers. So we have a lot of clients who have very few family members, maybe only one family member in the area. And that family member is their sole caregiver for all of their needs, for their food, all of their ADLs basically. And this gives the caregivers a respite as well as taking something off of their plate. So they have one thing completely taken care of that they don't have to worry about on a day-to-day basis. We also provide meals for other family members living in the home that may be reliant on the primary client for their basic needs, including any children or another older adult living in the home. So these are just some other ways that we try to help with not only meeting their nutrition needs, but their food and security needs as well. Because we have found clients, if other members of their family are are needing the nutrition, they'll give them the meals and not keep any for themselves. So it allows us to help provide for the family. Great, Nick, if you want to.
Thanks, Carrie Ann. So in addition to conducting kind of evaluation internally and sending surveys to our clients and gathering their feedback, we engage in quite a bit of external research and evaluation as well. We want to make sure, we know it's, I think everybody on this call after today has been able to kind of understand the impact of nutrition on health. But the more that we can kind of build up this evidence base around it, the more we can, gather support for these needs. And so in 2018, Project Angel Heart conducted a pretty rigorous study that looked at hospital readmissions and healthcare costs for our clients compared to a control group, so folks who were not receiving our meals. And we used data from the all payer claims database, the APCD, which looks at essentially insurance claims across a variety of insurers. So private insurance, state plans like Medicaid, Medicare, et cetera. And we found that there was a 24% reduction on average in healthcare costs when folks were receiving proper nutrition compared to kind of eating on their own. And that kind of translated to about a cost reduction of about $555. So it's pretty significant if you think of the number of folks who this study considered, and what that could kind of mean like for implications on a wider scale. We also saw that folks had a decrease in hospital readmissions, and that was kind of more pronounced for certain diagnoses. We saw that like heart failure, COPD, and diabetes for folks who were receiving meals with those diagnoses, the impact was even more significant.
All right, so we recently, as of May 1st, have expanded our delivery area all the way north to Greeley, Loveland, and Longmont and Brighton. So currently we cover from Pueblo to Colorado Springs, the entire Denver metro area, and then north to Longmont, and we're shipping to Greeley and Weld County as of May 1st. So that's been really exciting. And next year, we're going to expand our delivery area into Fort Collins and Loveland. So we deliver 7 to 14 meals each week by our lovely volunteers. They're delivered straight to the client's home, and it allows them, one, to have social interaction with our drivers, so that someone's at least seeing them once a week. And we're also shipping meals to, and we ship 7 to 14 meals as well. Yes, we do include Broomfield in the delivery area. The meals do arrive fully cooked but frozen, and we have a whole team of professional chefs here that change the menu each week, which offers the clients a lot of variety. And they can also choose anything, like Nick said, from a chicken dish, fish, beef, pork, and vegetarian meals. And you can see them right there in the picture. They come in like TV trays type. So, and there you can see our new beautiful truck that we deliver all across the state. So we're really excited about the expansion.
Thanks, Carrie Ann. So I know we're at time. We could probably spend all day talking about this. We love what we do, and we're very passionate about it, but we'd love to take the opportunity to answer any questions. I think Carrie Ann addressed Edward's question about the delivery area, including Broomfield. Yep. So right now we deliver across almost 1,800 square miles in Colorado, and that's just going to continue growing. We've also become a provider through Medicaid, or we're able to ship meals across the state. So we're really committed to making sure that folks get the nutrition regardless of where they live.
Question?
Question.
Yes, you've indicated a reduction in healthcare costs. Who is benefiting from those reduction in healthcare costs? And part of the interest is, along with some of the staff at the Area Agency on Aging, looking at social impact bonds to be able to possibly build infrastructure or support components to address maybe a broader area or deeper needs. Thank you.
That's a wonderful question, Phil. I can't speak exactly to that study. That actually predates me, so I'm not sure where that 500 number came from. But I know that currently we are seeing healthcare costs reduced for a variety of different parties. So our clients are reporting that they are seeing reduced healthcare costs and that they have fewer visits to their doctor, fewer emergency room visits and hospital admissions. So that's saving them money. They're also able frequently to cut back on certain medications or even not have to use certain medications anymore, which saves them money as well. And then of course, we're seeing those that translates to savings for the insurers as well, and our healthcare system. So a lot of our clients are utilizing like community health centers. And so if they're not having to visit those centers as much, that's saving them money as well. That's a great question.
You know, it's just amazing to me, the scale of what you do, and then the quality and diversity of what you're offering people. I mean, you must be doing something right organizationally to be able to, you know, do what you do.
Thank you. It amazes me too. We are very lucky to have such an amazing team of folks, but also just the volunteers, the community support, the buy-in. We have a staff of about 40 people, but we actually have over 8,000 volunteers every year who make this all possible. Many of them have been around longer than any of our staff, and there's just truly no way we could do it without them, and the support of the community. Different funders, including Dr. Cog, really make like this growth and expansion possible. We wouldn't be able to do it without them. But I agree, like seeing the quality, there's so much love that goes into every single meal. And we like to say, one of our common sayings around here is that we know that food is medicine, but it certainly doesn't have to taste like it.
Yeah.
But we want to send meals that people are really enjoying as well, because if they don't like the food, they're not going to eat it, and then it doesn't do good for anybody.
And Nick and Carrie Ann, thank you so much for this. It is wonderful, a partnership that we have with you. I remember the early days of Project Angel Heart. I've been around for a long time. We tried to partner for a long time with you all, and figure out how we could get, because you know the Older Americans Act has a lot of regulations. So how do we do this? And after a few years of trying, we finally got it done with Leanna's help, and so important. And you know, you've just grown and grown and grown, and clearly filling a need in the community. I always think about caregivers and how, oh no, this person can't have that because of this, so I got to do another meal for this loved one. How hard that must be, right? And to have you all there is that would be such a relief to say, here's your meal and I'll cook the rest of the family the meal that they need, or I'll eat what I need, but not have to go to that extra. And then worrying, I would be worried that somewhere along the line, I did something wrong to hurt this individual if they needed a medical diet. So that would be something that I think a lot of caregivers really appreciate.
Thank you. Yeah, thank you so much for the partnership.
There are more people that are going to get to partake of this webinar, because we will share the recording link on Dr. Cog's website. Plus, we will also be sharing the PowerPoints with our entire contact list. So there's a whole bunch more people who will get to benefit from this webinar. Our next two webinars are the fourth Monday of August, so August 28th and August 23rd. We do not yet have topics for those.
September 23rd, right?
No, August
28th and
October.
Oh,
20th.
October. Okay.
Woo! Yeah, And we'll be figuring out the topics for those webinars. Again, Nick and Carrie, Ann, thank you so much. And for those of you who have just like 2 or 3 more minutes, we are going to do a couple of Mentimeter questions to get your input. So if you can stay on, Mindy is going to bring up the Mentimeter. So basically, you go to your phone, your smartphone, and you get to www.menti.com, and you have a code that you'll enter. That's shown here. And there we go. There's our first question. These are really cool because you get to see the answers.
I think I entered the code wrong one more time. Can you just read it to me, Mindy or Kelly?
Kelly, I can't see it from my screen, so can you see it on yours?
Yeah,
So at the very top of the screen, Jayla.
Yeah. 959-3818.
Thank you.
The stoplight is filling up with responses.
Looks like it's stabilized, so I think all the answers are in.
Great. So the majority of you found this particular webinar to be very useful, and a smaller portion of you thought it somewhat useful. But everybody got something useful. So Mindy, let's go to our next question. What are your suggestions for future webinar topics? And I think it lets you enter a word.
Yeah, you can enter 3 different ideas.
So now we have a graphic of what people are requesting. And Mindy, you're able to save these results?
It'll give me the results, yeah.
Okay, thank you. So there are some suggestions: geriatric specialists, advocacy, transportation, housing, isolation mitigation, companionship, not to eat.
So is that what not to eat? Is that what that person meant?
That's
Oh,
what I think.
That's probably it. I didn't think they were saying not eating.
Yeah.
So that's it. Thank you all for staying on to give us this input. And I don't know, I learned a whole bunch today, so I found it very useful. You want to say any last remarks, Jay?
Just thank you for attending, and we look forward to seeing you in August. Thanks a lot. Thanks to the speakers.
Thanks. Go eat a nutritional lunch.